Good morning. Welcome to my channel RAD Academics. Today we are going to discuss on the topic Basic Principle of Radiography. Positioning terminology. So this is the anatomic position of our human body. Standing erect with the face and the eyes directed forward, arms extended by the side with the palm facing forward anteriorly, heels together and toes pointed forward, or anatomic terms refers to the anatomic position. So, the anatomic position is standing erect with the face and eyes directed forward, arms extended by the side with the palms forward anteriorly, heels together and toes pointed forward. All positioning terms refers to the anatomic position. Again, we are moving on to the body planes. How our human body is divided. It can be divided by a sagittal plane, mid-sagittal or median plane, coronal, frontal or mid-coronal plane, oblique plane, and the horizontal plane, axial. So what is meant by body planes? Body planes are the imaginary lines passing through the body in the anatomic position. As the body planes are of three types, first one is the mid-sagittal plane. Median plane is a longitudinal plane which divides the body into equal right and left portion, abbreviated as MSP. A sagittal plane divides the body into right and left section but not equally. These planes run parallel with the mid-sagittal plane. Mid-coronal plane is a longitudinal plane which divides the body into equal front, anterior and back posterior sections, abbreviated as MCP. Coronal plane divides the body into front and back sections but not equally. These planes run parallel with the mid-coronal plane. And the last plane is a transverse plane which divides the body into upper, superior and lower inferior sections. So these are the three planes. Mid-sagittal plane which divides the body into equal right and left portion. Mid-coronal plane which divides the body into equal front, anterior and back posterior section. And the transverse plane which divides the body into upper superior and lower inferior sections. So with that you understood the three planes of our human body. Again we are moving on to the body surfaces. Anterior ventral, that's seen when viewing the patient from the front. Posterior or dorsal, that's seen when viewing from the back. Here are the two images of showing the body surfaces. This is the anterior surfaces when viewed from the front, and this is the posterior surfaces when viewed from the back. Again, surfaces of the feet and the hands. The posterior sole of feet is known as the plantar aspect. The top of the foot or the anterior or the dorsum pedis is known as dorsum. And the palm of the hand, that is known as the anterior or ventral surfaces, is known as the palmar aspect or palmar surface. Again we are moving on to the general body positions. First one is the supine. When the patient is lying on the back, face up, then it is known as a supine position. When the patient is lying with the face down, it is known as prone position. When the patient is lying down in any position, it is known as recumbent position. And when the patient is supine with the head lower than the feet, is known as Trellenberg position, and the patient supine with the head higher than the feet is known as Fowler's position. And when the patient is in upright position, when the patient is standing, then it is known as erect position. When the patient is lying with the face up is known as supine position. When the patient is lying with the face down is known as prone position. When the patient is in any position is known as recumbent. Since the patient is turned to the right side, it is known as right lateral recumbent. Since the patient is turned to the left side, it is known as left lateral recumbent. And Fowler's position means the patient is supine but the head is higher than that of the feet. Whereas in Trellenberg position, the feet is higher than the head. But the patient is in supine itself. Then we are moving on to specific body position. Always described by the side or the sides closest to the image receptor. Erect or recumbent lateral position. Again we are moving on to a lateral position. Right lateral, then the right side of the patient will be closer to the image receptor, and in the case of a left lateral, the left side will be closer to the image receptor. So will you able to describe this patient position? This is the image receptor, and from this image you can see that this is the patient's right side, this is the patient's left side, and CR means the central ray. So the ray is coming from here. Okay. So which aspect, patient's which side is in contact with the image receptor? It is right side. So if your answer is right lateral erect position, then you are correct, since the patient's right side is in contact with the image receptor. So will you able to describe this patient position? So the patient is in recumbent, that the patient is lying on some side, any side patient can lie. And here the which side of the patient is in contact with the image receptor? Patient's right side is in contact with the image receptor. So if your answer is right lateral recumbent position, then you are correct. Again we are moving to the oblique position. The chest, abdomen or pelvis is rotated from the supine, prone or lateral position. The limb is rotated from the antero-posterior AP, postero-anterior PA or lateral position. So we have already studied or discussed how the patient is supine, how the patient is prone, or how the patient is in lateral. Okay. When we are rotating from such positions, it will be called as oblique positions. So, specific oblique body positions. Anterior oblique, as lateral, are described by the body surfaces closest to the image receptor. In the case of lateral, when we have discussed right lateral and left lateral, it was clear that the which side is in contact with the image receptor, that side will be termed as the projection's name. Right lateral means the right side is in contact with the image receptor. Left lateral means the left side is in contact with the image receptor. When we are moving on to the oblique positions, RAO, it will be abbreviated as RAO, and it is right anterior oblique position. In the case of a right anterior oblique position, the right anterior surface will be closest to the image receptor. In the case of left anterior oblique position, the left anterior surface will be closest to the image receptor. So it is clear, and we have got a clue from this that When we are saying one projection that right anterior oblique, you should be clear that the patient's right anterior surface is in contact with the image receptor. So, will you please identify in which position is this patient positioned? So this is the image receptor, and when we are viewing from the patient from the back, then it is known as the posterior aspect. So which aspect is in contact with the image receptor? Is the patient's right side or left side, and the ray is entering through the posterior aspect? So the patient is in oblique position. So which oblique position is this one? If your answer is erect right anterior oblique position, then you are correct. Then identify which position is this patient. Patient's anterior aspect is patient is in recumbent position, and patient's anterior aspect is in contact with the image receptor. So, if your answer is recumbent right anterior oblique, you are correct. In the first projection or in the first image, we have seen the patient is standing and anterior aspect is in contact. While in the second image, we have seen the patient is in recumbent position and the patient's anterior aspect is contact with the image receptor. Again, we are moving on to the specific oblique body positions. Posterior oblique. As lateral and anterior oblique position are described by the surface closest to the image receptor, right posterior oblique position means right and posterior surfaces is closest to the image receptor. Left posterior oblique means left posterior oblique position is closest to the image receptor. The same thing we have discussed above. When the patient's anterior aspect is in contact with the image receptor, we call this as right anterior oblique, and when the patient's posterior aspect, right posterior aspect is contact with the image receptor, then it is known as right posterior oblique. Likewise, when the left posterior aspect is in contact with the image receptor, it is known as left posterior oblique position. In what position is the patient positioned? Will you be able to identify this is the image receptor and the patient's one side is in contact with the image receptor and the patient's posterior aspect is in contact with the image receptor and the central ray is entering through the anterior aspect. So if your answer is erect left posterior oblique, then you are correct. Means the patient is standing, that determines the erect. Then the patient's left side is in contact, so left. Then the patient's posterior means back aspect is in contact with the image receptor. Then it is an oblique view. The patient have rotated, so the position termed as erect left posterior oblique. If this is the answer, then you are correct. In what oblique position is this patient? So the patient is recumbent and one side is in contact with the image receptor and the patient's posterior aspect is in contact with the image receptor. So if your answer is recumbent left posterior oblique, then you are correct. Since the patient is recumbent, patient's left side is in contact, patient's posterior aspect is in contact and the patient is rotated, oblique. So recumbent left posterior oblique, then you are correct. So An image taken in the right anterior oblique position will correspond with the image taken in the left posterior oblique position, and an image taken in the left anterior oblique position will correspond with the image taken in the right posterior oblique position. Hope you all have understood. Again we are moving on to the oblique projections of the extremities. Medial or internal rotation, the limb is turned in towards the median plane or midline of the patient. Lateral or external rotation, the limb is turned away from the median plane or midline of the patient. So this is the lateral rotation. When the patient hand is rotated, extremities determines the hand and the foot. When the hand is rotated outwards externally, then it is known as lateral rotation. When the patient's hand is internally rotated, then it is known as medial rotation. Again moving on to specific Decubitus positions, LLD. Left lateral decubitus position, the patient lying on their left side with the image receptor placed vertically and the X-ray beam is horizontal. Right left LD means right lateral decubitus position, the patient lying on the right side with the image receptor placed vertically and the X-ray beam is horizontal. So these are the images of some decubitus positions: ventral decubitus, dorsal decubitus and left lateral decubitus. Ventral decubitus means the patient is prone and a horizontal beam is used. So this is the image receptor. Okay, and we are exposing the patient using a horizontal beam. This is the dorsal decubitus. The patient is supine and horizontal beam is used, and this is the image receptor. And this is the left lateral decubitus. The patient is lying on the left lateral side. When the patient is turned to either side, then it is known as lateral position. And if the patient is turned to the left side, patient's left side, then it is known as left lateral. And when the patient is turned to the right side, then it is known as right lateral. And here we are using a horizontal beam for exposing the patient, and it is known as left lateral decubitus. Specific decubitus position, dorsal decubitus position, the patient lying on back with the image receptor placed vertically adjacent to a side of the patient and the X-ray beam is horizontal. Ventral decubitus position, the patient lying face down with the image receptor placed vertically adjacent to the side of the patient and the X-ray beam is horizontal. Both the dorsal and ventral decubitus position always demonstrate a side or lateral image. Radiographic projections. Projections are different from position in that they describe the path of the central beam CR or X-ray beam as it passes through the patient. The term projection always refers to the path of the central ray as it exits the X-ray tube, transfers the patient and reaches the image receptor regardless of the body position. So androposterior, again we are moving on to some projections, radiographic projections, androposterior. So briefly if we say that androposterior, from the A determines that the ray is entering through the anterior aspect. The first A determines the ray is entering through the anterior aspect, and P, the image receptor, is placed in the posterior aspect. It is a simple hint to remember what is meant by androposterior. The central ray enters the anterior body surface and exits the posterior body surface. The image receptor is closer to the posterior aspect of the patient, produces a posterior view. A view is the opposite of a projection. When viewing a radiograph, the term view represents a position. For example, if the patient is radiographed in the lateral position, then the image is said to be a lateral view. This is an image of an anteroposterior projection. Here we can see the X-ray tube, image receptor and the patient position. As I said before, anteroposterior. From the A, it determines that the ray is entering through the anterior aspect, and P determines the posterior aspect, and here we can see the image receptor is on the patient's posterior aspect. So, it is a hint to remember that when the ray is entering through the anterior aspect, then the projection is termed as anteroposterior. Posterior projections, PA projection. The central ray enters the posterior surface of the body and exits the anterior surface. Image receptor is closest to the anterior surface of the patient. So, from this, as I said before, when the ray is entering through the posterior surface, then the projection is termed as posterior projection. Then the image receptor will be placed at the anterior aspect. This is the image showing a PA projections. It is clear from that we can see the X-ray tube and the ray is coming and falling on the patient's posterior aspect, and the image receptor is on the patient's anterior aspect. So simply we call this projection as posterior projection. Again, moving on to the oblique body projections. Includes the thorax, chest, abdomen and pelvis. Right anterior oblique and left anterior oblique projections are posterior oblique projections because the central ray will enter the posterior surface of the patient and exits the anterior surface. Then oblique projections are described in some sort of other way. Okay, that means in here, before we have discussed as simply we say that right anterior oblique or left anterior oblique. We can either say from that term that the anterior aspect of the patient is in contact with the image receptor and the ray is entering through the patient's posterior aspect. Okay. In the case of right posterior oblique or left posterior oblique positions, or anterior oblique projections since the ray are entering through the anterior aspect. It is defined in some other way. We can determine or we can understand or we can study in a way that when we are speaking about anterior oblique position or left anterior or right anterior, just keep in mind that the patient's anterior aspect is in contact with the image receptor and the ray will be entering through the posterior aspect, and the other case vice versa. Projections of the feet. Feet are commonly imaged so that the central ray enters the top or the superior surface of the foot. So the anterior aspect of the foot is known as dorsum and exits the bottom or the inferior surface of the foot plantar. So the projection is referred to as the dorsoplantar projection. So when in the case of a foot, when the ray is falling on the topmost portion, it is known as the dorsum aspect, and the below portion is known as the plantar aspect. Again, we are moving on to the axial projections. Longitudinal angulation of the central X-ray tube towards the head is known as cephalad, or to the feet is known as chorded angulation. This is an image showing the cephalad and caudal shear angulations. This means in the above slides we have studied the position of a patient, how the patient is supine or prone, how he recumbent, then the patient is erect, lateral, decubitus. Many rotation, even oblique we have studied. So in some cases the patient won't be able to rotate. In such cases we will be rotating the X-ray tube. Okay, so if we are rotating the X-ray tube towards the feet, then it is known as chorded angulation, and towards the head it is known as cephalad angulation. Again, moving on to the tangential projections. The X-ray tube is directed towards the outer margin of the curved body surface to profile a bony part just under the surface or a surface lesion and project it free of superimposition. This is an image showing the tangential projection of the cheek bone or zygoma. This is the tangential projection of the kneecap or patella. Relationship terms. Medial, inside part closest to the median plane or midline of the body. Lateral, away from the midplane or midline of body. Proximal, near the source or beginning. In regard to extremity, the part closest to the trunk of the body. Distal, away from the source. In regard to extremities, the part further from the trunk of the body. Here are some relationship terms. Here you can see the median plane, proximal, distal part, medial arm, lateral arm. I mean the lateral aspect of the hand can be seen, medial aspect of the hand can be seen, median plane can be seen, proximal and the distal part can be seen. Kindly go through this image. Relationship terms. Cephalad means towards the head. Chorded means towards the feet. Superior means nearer the head or situated above. Inferior nearer the feet or situated below. Ipsilateral part or parts on the same side of the body. Contralateral part or parts on the opposite side of the body. Body movement terminology. Abduction. Lateral movement of arm or leg away from the body. Adduction. Movement of arm or leg away towards the body. Flexion. Bending or decreasing the angle of the joint. Extension. Straightening or increasing the angle of the joint. Body movement terminology. Eversion. Outward turning of the foot at the angle. Inversion. Inward turning of the foot at the angle. Pronation. Turning the palm of the hand down. Supination. Turning the palm of the hand up. Here are some of the body movements, extremities. Hope you all are clear with the class, with the anatomic position, body planes, body surfaces, body rotation and surfaces of the extremities, projections, movement, and if the patient cannot move or if the patient cannot rotate, then how can we take images? How in which all cases we are using a horizontal beam. Hope you all understood the class. Hope you all enjoyed the session. Stay tuned for the next topic. If you have liked this video, please don't forget to like and to subscribe my channel. Thank you so much. Good morning and welcome back to my channel PT RAD Academics. Today we are going to discuss about radiation therapy. So from the topic you understood that understanding more about radiation therapy. Radiation is used for therapeutic purpose. Therapeutic purpose means radiation is used for treatment. You might have heard about radiation before, right? When we are having some fall and immediately some swelling happens, and if we are having some fracture, we immediately, if we are suspecting some fracture, we immediately rush to a hospital for taking an X-rays. So X-ray is a type of a radiation, and through that we are acquiring X-ray images. With that, we are coming to a conclusion that whether we are having any fractures or anything we are having, with the doctor is reading or the radiologist is reading from the X-ray images. Likewise, the radiation is used for treatment purpose. Let us move ahead for more slides to know more about radiation therapy. So again we are moving on to the introduction. Radiation therapy, RT in cancer treatment. So from the first slide, from the first introduction, you understood that we are giving radiation as a treatment. So from this sentence itself you understood to whom we are giving this radiation. We are giving this radiation as a treatment purpose to cancer patients, and it depends upon many factors such as the type of cancer. Some cancers are very sensitive to RT, so it can be easily destroyed by radiation. Such example is lymphoma, and some cancers are resistant to treatment. For one example for that is melanoma. So depending upon the cancer, we will determine whether it is responding or sensitive to radiation or not. Then the efficiency of other modalities, or all the modalities should be used together or alone. So the oncology department comes under three branches: surgical oncology, medical oncology and radiation oncology. So when a patient comes to our department, for example a breast cancer patient is coming to our department, we have to determine many factors, or the doctor will be considering many factors for treatment. First is the patient's general condition. It determines the patient's age, sex, how healthy a patient is. All those factors will be coming under patient's general condition. Second thing is whether this cancer or whether this tumor is a localized one. Localized one means or a particular area will only be involved. Or if it is having distant extent of disease, means the cancer would have spread to different areas. So in such cases, which type of modality or which type of treatment should be followed will be determined by the radiation oncologist or the doctor or the specialist who is seeing this patient. And the tumor management decisions require multidisciplinary approach. So with this, before I have said one example, if a breast cancer patient is coming, and depending upon that lady's general condition and depending upon the staging of the tumor and all those things, we will determine which modality, whether this patient have to be sent to first for surgery, then the doctor will be reverting her to the surgical oncology department, and the patient will be undergoing surgery. Afterwards she will be coming under chemotherapy department. She will be doing chemotherapy, and along with that moving ahead with radiation. So depending upon the patient's physical condition, local and the distant extent of the disease, the treatment will be determined by the specialist. So each patient should be individually assessed by a team of specialists. Let us move ahead to a brief history of radiation therapy. So the first patient was treated with radiation in 1896. X-rays was discovered on 1895 by W.C. Röntgen. Then, back then, both doctors and non-physicians treated cancer patients with radiation. At that time itself, they started treating cancer patients with radiation. Rapid technology advances began in the early 1950s with cobalt units. Okay, so beginning was with cobalt units, followed by linear accelerator, tomotherapy, and now at last cyberknife. Recent technology advances have made radiation more effective and precise. These are the methods of delivering radiation therapy. In early 50s you can see, and you can see today what is happening. Radiation therapy, RT. Radiation therapy uses high energy X-rays. So from that sentence itself you understood that we are using X-rays for treatment. Yes, the mode of beam we are used in radiation therapy nowadays are X-rays. But the X-rays are different from that we are using in radiology department for taking X-ray images are different. Here we are using high energy X-rays. And it is aimed at the tumor to kill the cancer cells within it. These X-rays have been directed at the tumor with accuracy so that the cancer gets hit and normal surrounding tissues are secure. So the X-rays are directed to the tumor cells and that cells are killed by the radiation. Okay. In simple terms, the high energy X-rays work by damaging the cell nucleus and stopping the cell from dividing. The spontaneous division of the cells will be stopped with these X-rays. Normal cells can be affected. Some sort of normal cells can be affected surrounding this tumor site, but they are able to repair by themselves. Biological basis of radiation therapy. The cells can be killed by ionizing radiation. X-ray is an example for an ionizing radiation. Most important target appears to be nuclear DNA. Radiation damage to DNA result in non-viable offsprings. Rapidly dividing cell population. Yes, a cancer cells are rapidly dividing cell population which are more sensitive to the ionizing radiation. Okay, so we are using radiation as a mode of treatment for treating cancer patients. So the aim or goal of radiation therapy. The goal of radiation therapy could be simply stated as, it can be simply defined as deliver a high dose to all parts of the tumor while minimizing the dose to the surrounding normal tissues. So the main two categories of radiation treatment are radical treatment as well as palliative treatment. Radical treatment means to cure the disease. We have to get a complete cure to a patient. As I discussed in the before slide, the condition, the general condition of a patient is an important factor for radiation treatment also. Depending upon the condition and the staging of the tumor, we will determine whether the treatment is radical or palliative, whether that patient will be completely cured from the disease or whether the patient will get only relief from the symptoms of the disease. If that patient is getting only relief from the symptoms, In order to get relief from the symptoms, we will be giving radiation, and such type of treatment is known as palliative treatment. So let us meet the teams of radiation therapy or radiation oncology department, who all comes under that department. First is the doctor. As you all know, doctor is the main pillar for the department. Radiation oncologist is the doctor who oversees the radiation therapy treatment. Thereafter comes the medical radiation physicist. They have an important role in our department, ensures that complex treatment plans are properly tailored for each patient. Then comes the dosimetrist, works with the radiation oncologist and the medical radiation physicist to calculate the proper dose given to the patient. We are giving some radiation dose to the patient, and all those things will be discussed in next topic. I am not going deep into that areas. We will be discussing on that in our next topic, radiation units and measurements. Then comes the radiation therapist. We all belong to this category. Administers the daily radiation under the doctor's prescription and supervision. Radiation oncology nurses will be there. They will be taking care for the patient and the family by providing proper education, emotional support and tips for managing side effects. Types of radiation therapy. Radiation therapy can be delivered in two ways, externally as well as internally. Externally, we are giving radiation to a patient using a linear accelerator. It is an advanced modality, and in that we are using high energy X-ray beams. And the second thing is the internal radiation therapy called brachytherapy or seed implants, which involves placing radioactive sources inside the patient. This means the sources will be going inside the patient and delivering the radiation to that particular site. The type of treatment we'll use will depend upon the location, size and the type of the cancer. As I discussed in the previous slide, type of cancer is an important factor, location of the cancer is an important factor, as well as the size, how much size a cancer have begun. It is an important factor. So depending upon that, we will be giving external beam radiation therapy or internal radiation therapy. Is radiation therapy safe? Many advances have been made in the field to ensure it remains safe and secure. Multiple healthcare professionals review the treatment plan to ensure that the target area is receiving the dose of radiation needed. The treatment plan and equipment are constantly checked to ensure proper treatment is given. And what all are the workflow in a radiation therapy department will be discussed later. From that you will be getting more idea of about target area and how we are planning a patient for radiation. With that, I am coming to the end of this session. Hope you all understood and enjoyed the sessions. If you are enjoying my sessions, stay tuned for my next topic. If you like my channel, please don't forget to subscribe and like this video. We will see you soon. Until then, bye. Good morning and welcome back to my channel PT RAD Academics. Today we are going to discuss on generations of CT. CT means what? CT, the word CT you have always heard about CT scans, right? CT scans are computed tomography. The word CT means computed tomography and tomo means slices. So you have bought the bread from a bakery and sliced bread. Likewise, we are taking slices or cross section of our human body. So in the before classes I have described about positioning terminologies. In that I have discussed about different body planes. So the CT deals with the transverse plane. More about the components of CT I will be discussing in next sessions. Today I am dealing with only the generations of CT. So briefly I am saying the components of a CT. The more detailed version of the class will be seen in the upcoming topics. So here you can see an X-ray tube. Here X-ray tube. So the mode of beam we are using in CT scan is also X-rays. Then we are having filter. You can see here filter. Filters are used for shaping the X-ray beam by absorbing the low energy photons in order to reduce the skin irradiation or in order to reduce the skin dose. Then you can see here collimators and detected array, and all those things are the components of a gantry. This all comes inside a gantry. So X-ray tube is there, filter is there, collimator is there, detected array is there, as well as a gantry. Since the development of a very first CT scanner, so the CT scanner was developed at 1970s, the industry has seen a variety of changes applied to the CT scanner instrumentation, leading to the evolution of 7 different generations of CT scanners. Each generation of CT scanner is unique and varies based on the arrangement of the X-ray tube and detectors and how they move in relation to one another. So we are having 7 generations of CT, and CT was discovered in 1970s, around 1972, and it was discovered by Godfrey in Hounsfield. So we are moving on to the different generations of CT. The first generation is known as original EMI scanner or first generation CT. It is otherwise known as transit rotate CT. So here the detectors. When the case of first generation CT, there was only one detector. The type of beam was a pencil-like X-ray beam. The tube detector movement was transit rotate, and it was only specially designed for the evaluation of the brain, and the duration of the scan was average. It was about 25 to 30 minutes. So detector was only one detector, pencil-like X-ray beam. Transit rotate was the movement of the tube detector movement, and it was designed so the time it's a evaluation only for what, for the brain. It was only meant for the brain, and the duration of the scan was about 25 to 30 minutes. So you can see here the X-ray tube as well as the detector. There was only one detector, and the linear movement you can see in the figure how it was linearly moving. After one completion, the X-ray tube is rotating. Okay. So the first CT scanner was only for a head scan and used a rotate transit system with a single X-ray beam called a pencil beam. The beam was a pencil beam. In order to produce such a narrow beam of X-ray photon, the first generation scanner used a pinhole collimator. The collimator was pinhole to ensure only a single beam of X-ray was interacting with the patient. Only a single beam of X-ray was interacting with the patient. Now you can see a figure. The figure is not clear. Then also you can understand from this figure. The gantry moved through two different types of motion, one linear and the other rotatory. As I discussed, linear movement and rotatory movement, translate, rotate. The linear motion was repeated over and over 180 times. Between each of these 180 linear movement, the gantry rotated 1 degree. So, each of these was how many linear movements? 180 linear movements, and after completing 180 linear movements, the gantry rotated 1 degree from 0 to 1 degree. Thus, the total rotatory motion encompassed a 180 degree semicircle. The axis of rotation passed through the center of the patient's head, that you can see here in this image. The X-ray beam will be on throughout the linear movement. When it is moving linearly, the X-ray beam will be on, and when it is rotating, the X-ray beam will be off during the rotatory movement. So the total number of transmission measurements was the product of the number of linear measurements 160 and rotatory steps 180, which was 28,800 in the original EMI scanner. So this is what happening in the first generation CT. The major disadvantages of the first generation CT was time. Time was the main important disadvantage of the first generation, since to scan a particular area it was only meant for brain, but for a particular or a single patient or for a single scan it takes about 25 to 30 minutes. So the major drawback of the first generation CT scanner was the amount of time it took to acquire the images and to reconstruct the images using the computer. This process was very demanding in terms of both time and manpower. Again, moving on to the second generation CT, it is also known as transit rotate, same name as that of first generation CT, but it is different from that of first generation, since from a single detector the detectors have increased to multiple, that is up to 30 detectors. Around up to 30 detectors will be there. The type of the beam changed. From pencil beam it has been changed to fan shaped X-ray beam. And the tube detector movement is same as that of first generation itself, transit rotate, but instead of moving 1 degree at the end of a linear scan, the gantry rotates through a greater arc up to 30 degree. So in the first generation I have said you that there will be linear movement. Linear movement will take about 160 steps. After completing 160 steps, the X-ray tube will be rotating 1 degree. Likewise, the X-ray tube should rotate up to 180 degree. But in this case, the linear movement is there, okay, but the X-ray tube is rotating to a greater arc up to 30 degree. So somewhat the scan time have reduced. So the duration of the scan is average is less than 90 seconds. The largest advantage associated with the second generation CT scanner was the substantial decrease in acquisition time compared to that of the first generation. This generation of CT scanner was measured to be 15 times faster than the first generation. Here you can see an image, you can see the X-ray tube as well as the fan beam along with the detector. So this much area is covered with a fan beam. Again we are moving on to the third generation CT. Rotate. The name changes from translate rotate to rotate. So the detectors is multiple. It has also increased. Multiple. Originally it was about 288. Newer ones is having around 700 detectors arranged in an arc. So in a third generation CT, this third generation CT is now termed in another way as conventional CT. Here the detector number have increased to from 30 to around 700 detectors, and here we are using fan shaped X-ray beam, same as that of second generation, but the fan beam width have been increased. So that much area. So the single slice will be covering the whole area. Okay. Then the tube detector movement is rotate. The tube and the detector starts to moving rotate. That the linear movement have stopped. The duration of this scan average was approximately 5 seconds. So this is an image of a rotate scanner. You can see a patient lying on the couch. This is the X-ray tube, and down you can see the detectors. Detectors are in the form of an arc, and the X-ray tube is covering a single slice. It is covering from this edge of the detector to this edge. You can see in this image clearly. The X-ray tube is picked up by a row of detectors wide enough to image the whole slice. So the whole slice can be imaged. The two then rotate together to image a different angle. This is repeated until a single slice is scanned. The two then move the patient to start imaging a different slice. This is most commonly used method today and takes about 0.3 seconds to image a single slice. The peculiarity of this third generation CT is that when we are setting up the patient to the couch and when we are setting up, the X-ray tube and the detectors will be moving clockwise as well as anti-clockwise. For example, if we are imaging a CT brain, we will be covering from the area of interest is from vertex up to the base of the skull. If we are covering that much area and we are giving a 5 mm slice thickness, and we will be setting up a table index in this conventional modality, or setting up the table index, and once when an image is accurate, the table will be moving into the next slice position, and the tube detector will be rotating in the anti-clockwise direction. One clockwise rotation, one slice will be accurate, then anti-clockwise the tube detector system will be rotating and the another slice will be accurate. Likewise, clockwise and anti-clockwise rotation is happening in the third generation or in the conventional CT. Hope you understood third generation CT. This is another diagram of a third generation CT. The introduction and the wide aperture fan X-ray beam, which would reach the entire patient slice at one time. This specifically was what eliminated transitional motion in CT. That means we have eliminated the linear movement. In the case of a third generation, the linear movement has been completely erased. The increase in the angle of the fan beam angle have increased. The increase in the angle of the X-ray fan beam require the introduction of a longer linear detected array. This new array consists of about 400 to 1000 detector elements. In order to facilitate the synchronous rotation of the X-ray tube and the detector, these two parts of the CT scanner were joined so that they would rotate together. So these X-ray tube and the detector is connected together. Both will be rotating clockwise as well as anti-clockwise. So when the detector comes down, when the X-ray tube comes down, the detector will be moving up, and anti-clockwise. When the detector comes down, the X-ray tube will be moving up. So in each rotation, the slice will be acquired. The third generation CT scanners have two major disadvantages. Firstly, the addition of 400 to 1000 detector elements is much more expensive than only using 2 to 30 detector elements. Secondly, the third generation CT scanner produces a characteristics image artifacts known as ring artifacts. Regarding the CT artifacts, we will be discussing in the upcoming topics. So just mentioning here that this ring artifacts is usually seen in third generation CT scanner, and these artifacts are produced due to large number of detectors and the lack of calibration that is often present between the detectors. Fourth generation or rotate stationary detectors. So first one was transient rotate. Second was also transient rotate, third was rotate, and the fourth generation is rotate stationary. Here the type of the beam is same as that before, fan shaped X-ray beam. The detectors have increased, it have become multiple more than 2000, arranged in an outer ring which is fixed detector. So the stationary is what? Detectors is stationary and the X-ray tube is rotating, and the tube detector movement is rotate fixed. The duration of this scan is average to about few seconds. So here you can see the image. A stationary detector is there and the X-ray tube is rotating inside the detector. Fourth generation scanners were developed specifically to evaluate the ring artifacts produced by the third generation. Specifically, the impossibility to have such a large array of rotating detector elements greater than 400 are perfectly synced and calibrated to one another in order to avoid these ring artifacts. Okay. By removing the detectors from the rotating gantry and putting them in a stationary ring around the patient, and the detectors were able to maintain calibration. This stationary 360-degree ring of detectors require an increased number of detector elements of approximately 5000 total. So the X-ray tube is rotating inside the stationary ring or array of detectors. So once again the images are shown here. Just a revise. X-ray tube as well as the detector. You can see the X-ray tube at the top and the detector at below. In the first generation we are having only a single detector and we are using a pencil beam of X-rays. So the mode of beam in CT scan is also X-rays. And the linear movement is here. Once a linear movement have gone, the steps in a linear movement is about 160 steps is required to cover one linear movement. After 160 steps of linear movement, the X-ray tube will be rotating from 0 to 1 degree. Likewise, it will be rotating approximately up to 180 degree. So the scan time is more, about 25 to 30 minutes in the case of first generation. While in the case of second generation, the same linear movement is there, but instead of a single pencil beam, the beam has widened to as fan beam. Okay, and fan beam, and the detector is reading this fan beam. And after completing the linear steps, the X-ray tube will be rotating from 0 to 1. Like instead of rotating from 0 to 1, here it will be rotating up to 30 degree arc. Okay, so the scan time will be reduced compared with that of first generation. Again, moving on to the third generation, you can see the X-ray tube as well as the detectors below and the fan beam. You can see about 700 detectors will be there, and 360 degree rotation it is shown. You can see the arrow up as well as arrow down. That means clockwise as well as anti-clockwise it is moving. Continuous rotation is not possible in the case of third generation. It is otherwise known as conventional CT since it is of cable connection. So continuous rotation of the tube detector system is not possible in a third generation CT. While we are moving on to the fourth generation, you can see an array of detectors and the X-ray tube is inside the detector. Okay, and it is X-ray tube is rotating, so it is known as rotate stationary. Again, moving on to the fifth generation CT, electron beam CT, CBCT. So the X-ray source is not X-ray tube. Before, from the first to fourth, we were seeing that the X-ray tube. But here the X-ray source is not X-ray tube, but it is focused to a steered microwave accelerated electron beam. The electron beam, the production of the X-rays we will be discussing in the upcoming topics. So the electrons, when the fast moving electron hits the target, tungsten target, X-rays are produced. So EB means the electron beam. Okay. The electron beam which is generated is coming down. You can see in this figure, you can see the target and it is hitting on the target and the X-rays are produced from below. The patient is lying on the couch and the X-rays are produced and it is monitored by the detector which is seen up. You can go through the image. It has no moving parts. Everything is stationary. It is not having any moving parts. The target covers one half of the imaging circle and the detected array covers the other half. The scan time is less than 50 milliseconds. Sixth generation CT or the helical CT. This is the advanced one, helical CT, inaccurately called spiral CT. It is also known as spiral CT. Acquire data when the table is moving. Here we are getting a volumetric data of images. Here you can see the patient is lying on the couch. The table the patient lying is known as the couch. You can here see an yellow color, that is the X-ray tube, and the red color is seen as the detectors. And the continuous rotation of the X-ray tube and the detector is around this patient. And the table along with the table is moving. Okay. So continuous rotation of the tube detector system along with the table movement is happening in helical CT. So a volume of data is acquired. While in the case of third generation, as I said, we are setting up the table index as well as the everything we are setting up. Afterwards, we are acquiring when the X-ray tube and the detector is moving in one direction, we are getting one image on the screen. Afterwards, the table will be moving to the next slice. When we press the exposure button, it will be moving in the anti-clockwise direction. So, one rotation, one slice, second rotation, one slice, likewise slice by slice we are getting on the monitor. While in the case of a helical CT or the spiral CT, we are getting a volume data or volume of slices we are acquiring on the monitor. So the scan time will be completely reduced to seconds. Within seconds, the scan will be finished. So the helical CT or the spiral CT design is the X-ray tube rotates as patient is moved smoothly into the X-ray scan field. Simultaneously, source, rotation, table translation and data acquisition is happening. Produces one continuous volume set of data for entire region. Data for multiple slices from patient acquired at 1 second per slice. 3 technological developments. Why it is happening is that due to the slip ring technology. The slip rings are there inside the gantry which helps for the continuous rotation of the X-ray tube and the detector around the patient. Very high power X-ray tubes. Interpolation algorithm to handle projection data. Advantages of spiral CT: faster image acquisition, quicker response to contrast medium. Contrast medium we will be discussing later in the upcoming topics. Fewer motion artifacts, means motion the patient have a chance to move. So since the time is greatly reduced, the motion artifacts can be overcome. Improved 2-axis resolution. Physiological imaging, improved coronal, sagittal and 3D imaging, less partial volume artifact. It is another artifact which we have discussed about ring artifact. Likewise, this is another artifact of CT. Artifacts also we will be discussing in the upcoming topics. 7th generation CT. It is a new technology to overcome the limitations of single draw detectors. Hence, it has multiple detector array. The collimator spacing is wider and more of the X-rays produced by X-ray tube are used in producing image data. For detector array, instead of single detector array, multiple detector array is there and it is MDCT. It will be discussed in the upcoming topics. So a comparison between a linear array used in other CT generations A and the multiple detector array used in the 7th generation CT is shown in B. Hope you all enjoyed the sessions and hope you all understood. Thank you for your patience listening. See you soon with the next topics. If you have liked my channel, don't forget to subscribe. Stay tuned for the next topic. Thank you so much.